evidence that was already uncovered about irregularities. And so we then had to say it would, under these circumstances, it is best to bring in another agency to help us implement this project. And that is why we approached the national government, and they were able to appoint the DBSA to help us with this. Of course, Mr. Dakela will be managing the project right through until its completion. And we'll get regular reports from him. He will report both to us, to the Premier, and to the Minister of Health. Because both the Premier and the Minister are concerned about the completion of this project, and it is something that they prioritize. They will be expecting Mr. Dakela to brief them regularly to say what progress are you making. If there are any problems, he would obviously have to report such to them so that they can take necessary steps to resolve whatever problems that we find along the way. Okay, so I'll allow the Dr. Zungu and the CEO to deal with some of the issues about the healthcare, and of course the impact that Charlotte has.
Okay, let's first start with the CEO, then Dr. Zungu, then close the teacher.
I'm going to first try to address the issue of the impact of the hospital in terms of clinical care. The hospital runs 1,068 beds. We run 52 outpatients clinics every day, and we see about 74,000 patients every month. That's what we used to see pre-fire. And so as Prof. Miang explained, immediately after the fire, obviously the hospital closed completely. At the time of the fire, we had about 845 patients that we successfully moved to 17 different hospitals. And so there were services that we were sharing with Steve Biko, an example being the radiation oncology. And so it was not possible to take those ones to, say, for example, Chris Hani Baragwana, because they do not have the service. Mm-hmm. And if you take radiation oncology, our center is the biggest in the whole country. And so it was difficult for Steve Biko to absorb all those patients. And so some of the things that we did in terms of the radiation oncology was that not all patients had to get radiation. Some of them would be going through medication, others would be going for surgery, others would be in the process of being misdiagnosed. So the doctors sorted and sieved those patients according to the stage where they were. And so the ones for assessments, for example, they were asked to go to Bara to be assessed there, because you don't need those highly specialized to do the assessment, for example. Those who were doing medical oncology, the same patient, remember, can get medical oncology or radiation oncology. So the medical oncology, it was easy to set up at Bara because they are just nearby. All what we need is that we help them to immediately put a pharmacy, the proper pharmacy, that can mix and receive the pharmaceutical services that are related to those type of patients. So the possibility of opening the center was a very important one, because that was the main service that was putting a lot of pressure for the whole province, not only for Gauteng. But as you rightfully say, we do see patients from Northwest and other provinces, not only for radiation oncology, but also for example, renal, many of the conditions. And yes, you are correct. we have some patients being referred from SADC. And so what Prof. Moeng was trying to explain is that the clinicians said, if we have this 25 different services, how do we prioritize those that will have the major impact in terms of those patients not receiving patients? And that's how we opened the hospital first. Each head of department had to look at the type of services that they do and prioritize them according to that. The second thing that they did was that, remember, the area where the fire happened, unfortunately, is the area where most of these clinics that I'm talking about and the many highly specialized services are located, including the mental health wards. So that actually caused a major impact because suddenly we lost the 40 mental health beds that we had. And the patients who were coming here had to be accommodated at Helen Joseph. Maybe the one little fortunate part was that they had just finished one renovation of a 20-bedded ward, so we were able to immediately activate one mental health ward with the staff from Charlotte at Helen Joseph, but that is not enough. And I think the issue of mental health, all of us know it. And I think I mentioned that even our own staff are going through many challenges. Besides that, the COVID also led to a lot of mental health patients relapsing and coming back to the hospital. So what we did as the strategy, as we do block 1, the one that is being done by Solidarity, we can't get the 2 wards where they are placed. But when we get block 1, we will be able to open our day ward the ward that we used to use as a day ward observation into mental health. And with that, we have noticed somehow that majority of the patients who have mental problems are males. So there's a discussion going on between the psychiatrists in this hospital and Helen Joseph on how we could keep the male patients, because they are the ones who need more space and they keep the female patients. But our own psychiatric hospitals, Sterfontein and Tara, they really assisted in fast-tracking some of the admissions, because as you know, a mental health patient comes to us as an acute. Once we stabilize and they need admission for chronic care, they have to go to either Sterfontein or Tara. So they've been engagements. We have regular cluster meetings with them to update them on where they are, where we are, and all that. Some of the areas, I'll give an example with orthopedics, the hip and knee replacements. We were fortunate that Bethakwa had spare wards and ICU where we could continue with that work. It's not at the correct level where we want to, because we had a plan to try and reduce the waiting time for the hip replacements, but that was affected. Where there was a major impact was in trauma, because you can imagine if Helen Joseph is a smaller hospital than Charlotte, and the area in casualty where they keep the trauma patients is not, I think it's about less than half of our space. And remember, Charlotte Maxeke and Helen Joseph carry the load from the whole northern side right up to Deep Slot. So the pressure was at Helen Joseph, and it's still at Helen Joseph together with mental health in terms of that. However, some of the referring hospitals from Ekurhuleni and West Rand, our staff are still going there to try and deal with those patients as much as they can, like I had given an example with radiation oncology, so that we are able to diagnose. And I think, Prof, what we did is that because we do not have casualty, We even admitted patients directly from the casualty of those hospitals. Because once they assess the patient and they do whatever investigations they can, and they realize that this patient needs admission, we share the information with all the clinical people. They have an access to come directly to the wards and be admitted there. We have also put, there's a helpline, the quality department, when patients ask, and they have a way of dealing with the clinical team to say, must this patient come to Charlotte immediately, or can we refer them to another hospital so that we can be able to capture them? Remember, the patients who come here are many. Some of them had appointments at a later stage of the year. And so as things were changing, we tried to find a way of dealing with those ones. Have we caught up with all of them? The answer is no. We still are trying, because one of the other problems we picked up, for example, when quality was trying to contact them, when we tried to use the phone numbers that were in the, the red records, we couldn't find them. But what also gave us a little bit of comfort is that some of them who did not hear anything from us, they brought themselves here. And that's why our outpatients, we are grateful that they are there. We are unable still to accommodate all of them. But if you come in and you say, I haven't heard anything, we find a way. Either we'll stabilize you here, and based on what is it that you need, you will be referred. Because the very same doctors, for example, the orthopods, they are working at Hillbrow, they are working here, they are working at Bethakroa, but some of them are at Far East Rand. So they have that pipeline of saying, this one is relevant to go to whatever hospital that we think we need to have. In terms of the staffing, I think the question was who left. All categories of staff left. And remember, I said some of them were unable to tell whether they left because of COVID or other things. But I think majority of the people who left is the specialty nurses. They are in high demand everywhere. And as we speak, Prof. Muyang and Matron were saying, in terms of us opening casualty, we have to retrain quite a lot of them, because remember, we are seeing the very complicated trauma patients that are here. And that's why I said I'm grateful that those who are already in the system, we have started with that training. But we are also trying to recruit as many nurses as possible to come in. From the support staff, we did lose quite a number of them. But with the COVID posts that were created, they were able to assist us to patch here and there and be able to function. So not everything is perfect. There is still a lot of challenges, but we deal with them on a daily basis as and when they happen. Because sometimes we will stabilize this particular department and we find that there's another problem in terms of another one. And so it's a daily assessment of what is happening. I think I have answered all the questions.